I would like to welcome everyone at this roundtable discussion organized by the Center for Constitutional Politics. Today's discussion is about euthanasia, a question of life and death. I think it is important to underline that we are not just talking about life and death, but about deeply personal, painful experiences, personal tragedies, and we are talking about unbearable pain and unbearable suffering, both physical and both spiritual, and about situations where there is no good solution, and the best we ordinary people can do is to strive for empathy and compassion. In recent months, the spotlight has intensified on the topic of euthanasia in Hungary. As a Hungarian lawyer, constitutional lawyer who is afflicted with the ALS disease, has petitioned the European Court of Human Rights for his, and not just his, but also others' right to self-determination in end-of-life decisions, and specifically his right to seek assistance from a medical professional in his end-of-life decisions. His tragic case ignited broader discussions, including the proposal of a national referendum by one of the Hungarian political parties aimed at easing the criminal liability for medical professionals who, under very strict conditions, assist suffering patients in ending their lives prematurely. In today's discussions, joining us are very esteemed experts from disciplines of medicine, ethics, and bioethics, who will offer some insights and different perspectives on this complex and emotionally charged topic. Sitting next to me is Professor Nigel Biggar. He is Emeritus Regius Professor of Moral and Pastoral Theology at the University of Oxford, Faculty of Theology and Religion. He is the Director of the MacDonald Center for Theology, Ethics and Public Life. He received his Bachelor of Arts degree in Modern History from the University of Oxford, followed by a Master of Arts degree in Religious Studies from the University of Chicago. He obtained a Master of Christian Studies degree from Regent College, Vancouver, and he earned his PhD in Christian Theology from the University of Chicago. He also served as a chaplain and fellow of Oriel College, Oxford University, and held the position of Professor of Theology and Ethics at the University of Leeds. From 2004, he served as Professor of Theology and Ethics at Trinity College, Dublin. And from 2007 until his retirement in 2022, he had the position of Regius Professor of Moral and Pastoral Theology at the University of Oxford. And he was also appointed Commander of the Order of the British Empire in 2021. And he is the author of the book Aiming to Kill: The Ethics of Suicide and Euthanasia, published in 2004, 20 years ago. John Wyatt, next to Professor Biggar. Professor John Wyatt is Emeritus Professor of Neonatal Pediatrics, Ethics and Perinatology at the University College London. He is also a senior researcher at the Faraday Institute for Science and Religion in Cambridge. He worked as a pediatrician specializing in the care of newborn babies at a leading neonatal intensive care unit for more than 25 years. And through his clinical experience, he became increasingly aware of the ethical troubles caused by advancing technology and contentious debates about the nature of humanity at the beginning and also at the end of life. And he has now retired from frontline medical practice, and he is focusing on the ethical, philosophical, and theological issues raised by advancing technology. He does research on issues raised by rapid advances in AI and robotics and the interface between science and Christian faith. He is an author of numerous books concerning end-of-life decisions, including Matters of Life and Death, Dying Well, Dying Faithfully, The Right to Die, and also Death Without Dignity, Euthanasia and Assisted Suicide in Europe. Professor József Kovács is a doctor, bioethicist, philosopher, psychotherapist, and professor at the Semmelweis University in Budapest. He is Deputy Director General of the Institute of Behavioral Sciences and head of the Institute's Department of Bioethics. He graduated as a doctor from the Semmelweis University and then also obtained a degree in philosophy from the Faculty of Humanities at Eötvös Loránd University. He habilitated in bioethics at Semmelweis University in 2006, and in 2010 he became a doctor of the Hungarian Academy of Sciences in philosophy. He developed a curriculum for medical bioethics education in Hungary and written several textbooks to underpin this curriculum. For example, the Foundations of Modern Medical Ethics. These have been widely used for decades in Hungarian medical education, but also in other higher education institutions. And he has been involved in several pieces of health-related legislation, including the Hungarian Health Act. He also has several publications on the principle of informed consent, on the ethical problems of informing the incurable patient, and on the quality of life from a bioethical perspective. And also, I am Marton Csapodi, researcher here at the Center for Constitutional Politics, and I will be asking the questions during this discussion. And now that I have introduced everyone who's here on the podium, I also have to mention who's missing, because originally the idea was to allow sharply opposing views to clash on this occasion, and therefore we invited also János Kis, professor of the Central European University, who wrote an opinion-based piece on the case, emphasizing the idea that whatever the outcome, the most important thing is to have a public debate. And unfortunately, he declined to participate in this debate. However, I would like to at least virtually include him in this discussion and start with the point he made in this article that I have already mentioned. And he wrote that the life of no human being who is not a threat to others should be taken against his will. On this we surely agree, but the taking of a human life should not be prohibited because it is biologically alive. The only justification for the prohibition is that it is his life and no one has the right to dispose of it against his will. He has the ultimate authority to decide what to do with his life when he has the time and the means to give it substance, and what to do with it when its continuation is incompatible with his conception of life. So, in my conception, this argument for the legalization of active euthanasia or also assisted suicide is very clear and concise. From a non-religious point of view and a secular point of view, there is no intrinsic value in human life itself. Our lives are only as valuable as we hold them. As individuals, we have autonomy and the right to self-determination, and our right to self-determination includes the right to exclusively make decisions about our death. So how can this argument be at all questioned, and why would we allow any state to take away such a crucial part of our individual autonomy and the right to self-determination?
Shall I start?
Of course.
The position that a life has no value except what value the individual gives to it is, I think, not an accurate description, because I imagine most people understand that their individual autonomy, their freedom, should be limited by their social duties, that we have duties to other people. And sometimes the worth of a life consists in suffering, even because one has duties to other people. That's part of what makes a human life worthwhile. And for me, the crucial question is whether we can grant, whether a society should grant individuals the right to have assistance in committing suicide or to be killed, assisted suicide or euthanasia, voluntary euthanasia, can we do that without endangering other citizens or damaging society in other ways? And that's the crucial question. So the sheer assertion of autonomy is not enough. We have to ask, well, what are the social implications of granting this legal right? And I have doubts that we can grant a right to assisted suicide or voluntary euthanasia without causing significant damage to society or posing significant threats to other vulnerable citizens. That's the issue.
Thank you. So you don't believe that we have a right to self-determination because it damages other citizens?
Well, I don't think we have a an absolute right to self-determination, society couldn't exist if we did. We all live in societies with laws. Those laws limit our freedom. And even if we don't have, as it were, civil laws, there are moral laws and requirements that constrain our freedom. Some people may deny that their freedom should be at all constrained by either moral law or civil law. Most of us, whether we're religious or not, recognize that at least social life requires the limitation of individual autonomy, and many of us, religious or not, would recognize that a lot of the value of our individual human lives comes from our meeting our social obligations.
Thank you, and I would like to also ask Professor Wyatt and Kovács whether they agree with Professor Bigar or Professor János Kis.
I think that there are basically two lines of arguments here, and it begins in ancient times. Even the Stoics began to say it. The first is the sanctity of life argument, or respect for life argument, which is quite old. And I think the other is the Stoic view, which is the quality of life argument. If somebody accepts the quality of life argument, the Stoics accepted it, it means that life is valuable only insofar as it has more positive than negative experiences, and there is a certain point where life is so burdensome that it has to be finished, and the Stoics did it, that it was called exagoge, go out of life. While the sanctity of life or respect for life says that life has intrinsic value even if it's full of suffering, and so you cannot help in killing. There is a famous example of an Oxford philosopher here who considers a hypothetical example when there is a truck which is full of petrol and there is a crash, and the driver is in the car, in the truck, and he cannot be extricated, and it's on fire. And there is a policeman outside, there is a big mass, and they try to save him, but it's evident that he cannot be saved. And the man sees the policeman and asks the policeman to shoot him, to kill him, because it's evident that he will die, but it's not the same to die in 4 or 5 minutes in fire or to be killed. And of course the policeman didn't shoot him, but the question of here, that if we imagine ourselves in the situation of that truck driver, very few people would say that active help in killing, mercy killing, is absolutely prohibited. And he says the golden rule that do unto others what you would have them do unto you. So I think such terrible situations exist when somebody has so much suffering and there is so little hope that for him death is better than life. But of course these are desperate situations, and it's another question whether a society can accept this, whether it can allow. For instance, I think no society would allow a policeman to shoot in this case, although we feel that perhaps it would be justifiable from a moral point of view. But what would happen if this would be widely accepted from a legal point of view? So that are two different questions. I think we can always cite examples when there are terrible suffering, which we are not willing to hear. And ordinary people who are not doctors can turn off the television or simply don't hear the news. But the doctor must be there and must help the patient. And that was the argument in the Netherlands. They said that this is vis maior, so there are two obligations. The first is to prolong life, but the other is to ameliorate suffering. And when these two goals are incompatible, that's the reason that when the doctor helps the patient, he will not be punishable.
Could I make a brief comment? So I agree with you that there are extreme cases, that the one you cite, where if you consider the case alone by itself, shooting the person about to burn to death seems the moral thing to do. But in your description, you talked about that being moral, and you contrasted it with, as it were, the social view, or I guess I'd say, I describe it a bit differently. I'd say when you consider the case alone in abstraction from larger society, it seems moral. When you step back and consider, well, if I allow this in this case, will it have widespread social ramifications we don't want? I would say then, as it were, from the larger perspective, morally, one shouldn't do it. So it's not a contrast between moral and social. It's more a matter of whether your moral perspective is narrow or whether it's broad. So my view is, all things considered, it would be wrong to do.
Okay, I think that's the slippery slope argument, which always comes up, namely that if we allow such things to happen, we start on a slippery slope. We don't want to go down, but ultimately we will go down to the end of the slope, because we find only justified cases, and there are some justified cases, but of course we don't want to go further, but the logic of the thing will force us to go down. And I think today it's easier to discuss this thing because there are empirical examples. There are already 9 countries in the world which legalize active euthanasia, and the Netherlands is perhaps the oldest one. It's 20 years history, and before 2002, when it was legalized, there is 30 years of experience when it was not legal, but it was not punished. So 50 years experience. And I always think that the Netherlands and some other countries are a kind of laboratory. We can test the hypothesis of the slippery slope argument, namely that it will be devastating, it will lead to the corruption of the society or not. Of course, we don't have enough perspective because 20 years is not enough, but as far as I know, in the Netherlands, there is no very much abuse, so people are satisfied with their situation. Perhaps there are some cases of abuse, but basically there is no abuse. Of course, this is not proof that in other countries there would not be an abuse, because the Netherlands is very rich, it's very democratic. I always say that in Hungary it wouldn't be allowed, it shouldn't be allowed active euthanasia because Hungary is not so rich, and in such a country it would be very dangerous. And I think the majority of the countries in the world are not so poor as in the Netherlands. So even if in the Netherlands there is no abuse, it's not sure that in other countries there would not be an abuse.
Just before John needs to speak, but why is being rich or poor important?
Pardon me?
Why does it make a difference whether a society is rich?
I think the difference is that if you are suffering because the healthcare system is not good enough and you simply can't have access to important things which otherwise could have been accessed, then you are not autonomous. So people are forced to go to this option to have suicide or active euthanasia, when in fact they are simply only poor and they can't have access. And that would be a terribly inhumane society which wouldn't provide healthcare system, but would say that, look, if you are not satisfied with the situation, you can choose active euthanasia. So that's absolutely inhumane, and I think even people in the Netherlands agree with that, that only in a very, very rich society is acceptable euthanasia. If it's acceptable at all, of course, it depends on the moral view and worldview, but if it's acceptable at all, it's acceptable only in a very rich society and in a very rule-following society, in a democratic society, when you can be sure that people are respecting the rules, where people trust those people who are doing euthanasia. For instance, in the Netherlands, this criterion is fulfilled because patients trust their physicians very much. So where there is, all these criteria exist, then it can be considered whether it's acceptable or not. But most of the countries are not like that.
Yeah, I'd like to suggest there's another laboratory country, which is actually the UK. So euthanasia has been discussed in the UK longer than anywhere else. It was being discussed in the 19th century, and there were debates going on as to whether some kind of active killing of people whose lives were thought to be worthless was being widely discussed. But in the 1960s, when it was, again, there was in 1950s and 1960s, there was a lot of discussion. A very different movement emerged for the care of the dying. It actually started in London, where I practice, and I know quite a lot about the history of this. And it was a movement which was completely different from what happened in the Netherlands. At the same time that the Netherlands, what was as been said, what the development in the Netherlands was the doctors said, I have an absolute duty to prevent suffering, as well as an absolute duty to save life. What do I do when there is hopeless and unbearable suffering? I must kill the patient. I have simply no other alternative. What happens to the doctors in London was they said, we will find a better way. We will find a way of caring for patients which doesn't involve killing them. And the pioneer, Cicely Saunders, one of her famous statements was, you don't have to kill the patient in order to kill the pain. And she developed a completely new way of caring for dying people deeply traumatized by pain, which involved using the very best knowledge of painkillers. She developed a lot of new expertise in the pharmacology of different pain-killing medication. But one of her greatest insights was to realize that pain at the end of life is not purely physical. And this seems to me such an important point, which I'm afraid the general public just do not get. When they imagine someone at the end of life in pain, they imagine the sort of excruciating pain, like a broken limb or some horrific physical agony, which the doctors are powerless. They're wringing their hands. The pain is just going on and on indefinitely. And in the end, you say, kill me, I cannot tolerate this. That is not the reality of what pain at the end of life is like. In fact, the physical pain, what Cicely Saunders recognized was that actually there were 4 components to pain at the end of life. There was physical pain that I've just described, but there is also psychological pain, which is all to do with depression, anxiety, fear, all the stuff going on inside our heads. Then there is relational pain. So many people at the end of life have broken relationships. And this causes a genuine agony at the end of life as you recognize your life is coming to an end. And then there is spiritual or existential pain, which all people, atheists as well as religious believers, are prone to. And she recognized that you have to address all 4 kinds of pain simultaneously, and with a really detailed holistic care which involves psychological counseling, it involves relational and social support, and it involves also spiritual or existential support, that in all cases the pain could be significantly ameliorated, and in many cases you could transform the end of life into a completely different experience. And because palliative care has turned out to be so successful in the UK, 60 years later, we still have no euthanasia. Euthanasia and assisted suicide are illegal and are not being practiced. It is true, we have a small number of people who go abroad, usually to Switzerland, for assisted suicide, but the figures are approximately 30 to 50 a year from the UK, which you compare that with 500,000 people who die every year in the UK. So we're talking about 0.01%. So my contention is, yes, there are rare and terrible cases, and I am not claiming that in all possible cases that palliative care and so on is successful, but nonetheless, it's a better alternative to care at the end of life, and that we should be investing resources in palliative care. And I think the reason that Netherlands went by a different route was that palliative care was very much less well developed at the time. It's true now that palliative care services are being developed across the world. They're being developed here in Hungary. And my contention is it's better to put the emphasis on palliative care than it is on making potentially dangerous changes to the law to allow some form of medical killing.
John, sorry, your name? Joseph. Do you know how well developed palliative care is in Hungary?
I think it's developed. Of course, there are problems. Not everybody have access to it, but there was a considerable development in palliative care. And Cicely Saunders was the example, I think, everywhere in the world, so in Hungary as well. So we have palliative care. But to tell the truth, we already discussed this thing before we began this discussion, that in the Netherlands, according to statistics, 80% of the people who get euthanasia and request active euthanasia are getting palliative care. So the problem is, at least in the Netherlands, that it is itself not enough. And perhaps we can say that it's not a developed palliative care, it can be further developed. But you know, there are situations when people feel that their suffering is unbearable. So, but I think that there is a third form of treatment, which perhaps palliative care, which is called continuous deep terminal sedation, or which knows almost everything what active euthanasia knows, and still it's not killing the patient because it makes the patient in a comatose state. It can be used only 1 or 2 weeks before death, but still it exists. And some people prefer that to active euthanasia because sometimes the suffering is such, as you mentioned, that it is not physical suffering, it's something different, which is existential or something like that, which cannot be treated in any other way. Or fear of death, for instance, is also a form of suffering. So continuous deep sedation is, palliative sedation is perhaps a tool for that.
We may not have, to conclude, we may not have a right to self-determination and a right to suicide, but in fact we have, it's not a right to suicide, but an opportunity to suicide. And suicide is not prosecuted by law, in fact. So when we feel that life has become an unbearable burden, then we can get rid of our precious lives without any concrete legal consequences. But then there are those who, due to the nature of their disease, are unable to commit suicide. Isn't it discriminating to practically allow everyone to kill themselves without any legal consequences, except those who, due to their extreme suffering from a disability and would need the help of others to do so?
So, speaking for the UK, my understanding is there is no such thing as a right to commit suicide. It's simply that if you commit suicide, you won't be prosecuted. It's not criminal. So society doesn't say that you have a right to it. Okay, but some people, should they choose, can commit suicide to avoid whatever pain they suffer from and feel is unbearable. Other people can't do that. Should other people therefore be assisted to do it if they can't do it themselves? But again, I come back to the question, well, yes, perhaps, provided we take into account what the large-scale social effects of that would be, because when a society grants a right to something, one has to take into account what's this going to cost, what are the implications, and it may be that, as in the UK, we decide that the social risks, the risks to the vulnerable, the risks to the general commitment that we want citizens to have to help each other in adversity, not to kill each other in adversity, that we consider that would be damaged, and therefore we cannot grant people the right to assisted suicide. Now, that may leave some people in very difficult circumstances, and my view is there is no solution to this problem. On either side, there are risks. So we could try and solve the problem of some people in desperate circumstances. We do that, we will put other people at risk of being pressured into choosing suicide they don't want, but they choose it because they've been abandoned. So my view is there is no clean solution, and one of my criticisms of those who lobby politically for legalization is they do not tell the whole truth about the risks. But in terms of the discrimination against people who cannot commit suicide by themselves, I guess my view is there's no right to suicide. It is true that some people can do it more easily than others, but whether we grant a right to assisted suicide should depend on our judgment about what the social effects of this will be.
I think one of the things which is important to remind ourselves about is the extraordinary efforts that modern societies go through to prevent suicides. In the UK, every single doctor, every nurse, every health professional, every paramedic, every policeman, every social worker, every prison officer have detailed training on how to spot people who are at risk at suicide and what steps to take, including, if necessary, quite draconian steps of forcible intervention in order to prevent suicide. And of course, there are organizations like the Samaritans and many other non-profit organizations and so on, again, totally devoted to trying to minimize and reduce the amount of suicide in society. I myself have, tragically, a number of people who are close to me and children of people close to me have committed suicide. And I'm aware of the utterly devastating and lifelong consequences to people from the suicides of close loved ones, including one case in which an elderly man in the Netherlands, his son and grandson and family were living in the UK, and one day he informed them that he was about to have euthanasia in the Netherlands because he had some chronic pain and he was lonely and he wanted to end his life. And the doctor had agreed to do it. And my friend, his son and the grandson flew over to the Netherlands and pleaded with their father not to kill himself. But he went ahead and did it, and they were just left devastated with the loss of their grandfather and father who they loved. So the point is that what this illustrates is our intuitions, is that suicide is not just a question of individual choice and individual rights. It has widespread social impact. And I'm reminded of the famous poem by John Donne, "No Man is an Island," which is really, which is a reflection on this very point. He said that any man's death diminishes me because I am involved in mankind, and therefore don't send to for whom the bell tolls. It tolls for thee. Now that is, I think, an understanding of society that we are all locked together, whether we like it or not. We are locked in relationships. We have responsibilities and duties, and what you do with your life affects me. What I do with my life affects you. That's what it means to be a human being. That's what it means to be in a society. And instead, what is being promoted, and a lot of this is coming from the Anglo-Saxon world, particularly from America, is a kind of hyper-individualism, which basically regards human life as just a collection of atomistic individuals. We just live our lives, we choose, and whatever the people think, it doesn't matter. In the end, it's my choice, my life. I stay alive as long as I want, and when I don't, I top myself. And so we have these two quite different visions of society. And my question is, which vision of society makes sense, and which vision do we wish to reinforce? And it seems to me, I would much prefer to be in a part of a society which opposed suicide, which attempted to encourage these kind of bonds of that everyone's life matters, rather than be in a society which decides that there are some suicides we oppose, but we've now got a category of a kind of approved suicide, or rational suicide, or justified suicide. And we now distinguish between this group over here, where we think that's a bad thing, and this thing, okay, well, this is quite a good thing, we'll tolerate this, we'll pay for it, we'll provide a medical system for this to be facilitated. And I personally feel that is not the direction that we should be going in our society.
I think most societies don't recognize a right to suicide because, in spite of the fact that it's not punished in most societies, in other times it was punished, but now it's tolerated. Because if we accept a right to suicide, it means that we cannot prevent somebody to exercise his right, or perhaps we must help them to exercise their right, which is not done in many societies. But I have to tell that a German constitutional court some years ago said that from the German constitution, it can be inferred that there is, from self-determination, it can be inferred that there is a right to suicide, and to prevent people to help others, for instance, to go to Switzerland and there is a help in suicide, would be unconstitutional. And many German citizens went to Switzerland and they were not prosecuted against. But the problem which you posed is real, because this was the argument in the Diana Pretty case in the United Kingdom, where there was a woman who couldn't commit suicide because she was immobilized, paralyzed, and she said in her submission that everybody else can commit suicide, even though they don't have a right to it, but she can do it herself. But she cannot because she is disabled, and she wanted her husband to help her, but the husband would be punished because help in suicide is punishable. And she said that there is a discrimination by the law, and that was the argument in front of the European Court of Human Rights, but they rejected that. They didn't accept, although I think the argument is convincing, because a disabled person doesn't have the same possibility as an able person because of this legal change. On the other hand, it's interesting that in the Netherlands, there was a legal professor who in 1991 had a proposal. He said, his name was Trion, and this was called the Tablets of Trion. He said that after the age of 75, in a modern society, everybody should be given a tablet, which is Trion, and with this, he could kill himself or she could kill himself painlessly. Because today, if somebody wants to commit suicide, he has to do it in a brutal way, hanging or jumping out of a tall building or something like that, which is terrible, and it's not humane. But with this tablet, everybody could commit suicide in a humane way. And the advantage of this was the argument of Drion, is that people would tolerate pain for a longer time, because, and he used the argument of a building in fire, and if the door is open, then you can try to extinguish the fire, because you know that you can escape any time. But if the door is closed, then your first consideration will be to try to escape, because you know that you can't escape whenever you want. So this was his argument, that it would make less suicide and not more suicide. In the Netherlands, it happened because today these tablets are available, and usually people are advised, and there is public libraries, you can read how to do it. When I was first in the United States in 1990, there was published a book about how to commit suicide in a right way, because this is the type of do-it-yourself books, that how to paint your house, how to, and the experience was that people can't do it well because they try it, but they fail, and they wanted to give some suggestions how to do it well, and there was a very big debate whether freedom of the press and prohibition of this book is compatible, because they felt that this book is very dangerous. But this was in 1990, because in the Netherlands, such advice is publicly available in libraries, there are videos, TV programs, so it came close to the right of suicide. But the problem, and it is called self-euthanasia, not suicide, because suicide is secret. If there is no right to suicide, then you have to do it in secret, because otherwise you have to prevent it. But if you have a right, it doesn't have to be secret, and that is the reason that it is called self-euthanasia, because the family is there, everybody knows what is happening, nobody does anything active, only the patient with the tablets or methods which is given to him, but no physician is involved, no relatives are involved. So this is called self-euthanasia. But I repeat that I think in most societies there is no right to suicide, because it has very far-reaching consequences if we recognize this right, because then we have to not to interfere with people who are exercising this right.
Thank you. And also another interesting problem for me is that most modern legal systems allow some forms of euthanasia, at least passive euthanasia, in Western legal systems. And now the debated question is the so-called active form of euthanasia and assisted suicide. But for me, it is really hard to see any moral difference between the two. For example, in most criminal law systems, we do not really differentiate between, as to the punishment, between killing a person deliberately and also deliberately letting a person die in front of us. So, and I also thinking about whether there is a difference between a machine and the bodily organ. So, whether is there any moral difference between deliberately stopping the heart beating, or stopping the lung deliberately, or just stopping the machine that keeps the lung or the circulation working?
Could I respond to that? The terminology of active and passive euthanasia was quite popular 20, 30 years ago, but actually nearly everybody who works in this field has decided that it's deeply confusing terminology and that it should be abandoned. And certainly in the UK, we never use this distinction between active and passive euthanasia. The definition of euthanasia, which is generally agreed, is that it is about intentional killing in a medical context. It is the intentional ending of life by medical means. And in other words, the stress is on the intention. So when a doctor is involved in euthanasia, I mean, it's quite interesting, slightly grisly point. When the first doctors started killing people, which was in the Netherlands, they didn't know how to do it. It wasn't the kind of thing you got taught at medical school. And so there were a whole series of rather grisly experiments when they tried various things like injecting air in people's veins or huge doses of insulin or breathing helium gas or various other things before they'd worked out a nice, clean and effective way of killing. But the way that is routinely used now involves a massive dose of an old-fashioned drug called barbiturates, usually 50 to 100 times the therapeutic dose, coupled with another drug which is intended to stop muscles of respiration. It causes instantaneous paralysis of the muscles. So the combination of these drugs brings instantaneous coma followed by inability to breathe, and very rapid death ensues. And it's extremely effective, and it happens at the end of the needle. And the point is that those drugs are never used in palliative care. In other words, the way the drugs that are used in palliative care are completely different from the drugs that are used in euthanasia because the intention is different. In euthanasia, the intention is to kill rapidly, cleanly, and irreversibly. In palliative care, the intention is to treat the symptoms but allow death to occur by natural processes. And so the intention is quite different. And legally in the UK, that is recognised, that allowing a patient to die by natural processes, sometimes we're withholding and withdrawing life-sustaining treatment. When the patient dies, they die as a result of the disease process. By contrast, when a patient dies because of a lethal injection of these toxic chemicals, poisonous chemicals, the cause of death is not the disease process. The cause of death is toxicity, direct effect on the brain and the muscles. So it is the choice of drugs illustrates the intention, and it's the intention which is the heart of the moral difference. I personally, as a physician, have many times withdrawn life-supporting treatment in extremely sick patients, including babies and children. But in those cases, my intention was never to kill. My intention was to stop treatment which was damaging and destructive and bringing no benefit to the patient. In some cases, the patient actually survived, much to my surprise. But in those cases, we didn't then say, right, well, I'd better do the job cleanly and go and get the euthanasia drugs. What we did is we supported and cared for the child and provided basic support and so on. So in other words, there is a very clear, in my mind, a shining line between intentional killing and withdrawing treatment which is bringing no benefit.
I think there was a very famous article of an American philosopher, James Rachels, which was published in 1975 in the New England Journal of Medicine, which is quite rare that a philosopher publishes something in a very prestigious medical journal. But this happened, and it became a very influential article, which says he was against this distinction of active and passive euthanasia. And he says that there is no distinction between doing something actively and allowing something to happen if the intent is the same and the result and the consequence is the same. And he has a hypothetical example that one is taking care of a child and he enters the bathroom and wants to kill the child is having a bath, and he pushes the child's head under the water and he kills him. This is active killing. And he says the passive form of this killing is the same. He enters the bathroom, he wants to kill the child, but the child slips on the soap and falls face down into the water. He is there. He could save the child, but he doesn't do it. He doesn't touch the child. He simply is there and allows the child to die. And his question is whether is it the same or not. And his answer is that it is the same. In the first instance, I did something actively, and in the second instance, I tolerated to happen, although I could have saved the child. So it's the same morally. And this became a very influential article because, of course, he wrote this because at that time active euthanasia was not permitted anywhere. Passive euthanasia was widely accepted by doctors. And he asked that why is it the case that passive euthanasia is tolerated and active euthanasia is prohibited? And he made various explanations. And I think that was a time when countries began to start into two different directions. Some countries, the Netherlands was the first, said that if active and passive euthanasia are the same and passive is accepted, then we have to accept active euthanasia as well. And they did a lot of things to this happen. But only some countries followed this route. The other way, and I think the majority of countries went in that way, said that if active and passive euthanasia are the same and active is not acceptable, then passive is not acceptable either, and we will not tolerate passive euthanasia either. And I think this is the route most countries said, and I totally agree that in the case of passive euthanasia, it is not passive euthanasia, but the patient refuses life-saving or life-sustaining treatment. The doctor simply respects this. He cannot treat a patient against his wish. His intention is not to kill the patient, but the patient doesn't allow him to save his life or to sustain his life. So I think it's not the case that passive euthanasia is accepted. Many people say that it's accepted in Hungary. It's not the case. But is accepted is for a patient to refuse life-sustaining treatment. But the intention of the physician is not to kill the patient, but to respect his right to be treated according to his values. And I think that's an important distinction. But today, usually people say that the real difference is not between active and passive. The real difference is whether it's voluntary or non-voluntary. Voluntary means that the patient requests it, the patient refuses life-saving treatment or life-sustaining treatment. That's voluntary. But his problem, and what has happened a lot in earlier times, that physicians unilaterally decided that they will not treat the patient. For instance, in the 60s, 70s, it was the case that they decided not to resuscitate the patient. The patient didn't know that, but of course the patient was in a terminal situation, metastatic cancer, and they simply decided not to resuscitate. And this is involuntary euthanasia because doctors did it in the presumed interest of the patient. They wanted to do him good, but they didn't involve the patient, and that's the reason that it's involuntary euthanasia. And the argument became that voluntary euthanasia is more acceptable, even if it's active, than involuntary euthanasia, even if it's passive. And that's the reason that since the 70s, 80s, patients should be consulted in the case of, for instance, a terminal disease, whether they want to be resuscitated or not. And they can say that I don't want to be resuscitated, and it is written on the document of the patient. What is not accepted is to make a unilateral decision by the doctor and not involving the patient to decide that I will not treat him, I will not save his life, I will not use life-sustaining treatment. That's unacceptable because it's a violation of the autonomy of the patient.
Thank you very much, and I would like to also ask Professor Bigar what he thinks about what the other professor just said, that basically a person with a terminal illness has a kind of a right to self-determination, but a person without a terminal illness hasn't.
So that's one of several slippery slopes I worry about, because it's not clear. If someone is suffering unbearably, whilst they're in the process of dying, why would you aid them but not aid someone who's suffering unbearably in the same way, but just not close to death? So, in other words, why grant the right to the terminally ill but not to the chronically ill? And so one slippery slope comes through this concept of unbearable suffering, because the chronically ill could be suffering as unbearably as the terminally ill. And of course, who decides when suffering is unbearable? Who decides that? Because depending upon my resilience, what I find bearable, you might not, or vice versa. So the tendency tends to be, in jurisdictions where unbearable suffering is the critical criterion, it tends to become entirely subjective. I haven't had a chance to corroborate this, but from what I've read recently about the Canadian situation is that if someone deems themselves to be suffering unbearably and does not wish any alternative remedy other than euthanasia, they have a legal right to choose euthanasia. No one gets to define what's unbearable except the person suffering it. So it seems to me, if that's your criterion, then whatever the initial limitations on eligibility, those will crumble and lead in effect to assisted suicide or voluntary euthanasia on demand by any adult.
I think that absolutely true, because in the Netherlands this was a problem, because first they began to do euthanasia for somatic reasons, but then unbearable suffering can have psychological reasons or social reasons. And first psychiatrists were very resistant to do it because they said that cancer kills a person, but anorexia or depression not surely kills somebody. One can be treated or one can be cured in case of depression. And so the first psychiatrists were resistant and they didn't want to indicate euthanasia. But the problem went further because there is not only psychological suffering, but social suffering or suffering from social causes. There was a case when somebody was sentenced to life imprisonment, and he said that life is intolerable to him and he wants assistance in dying. Another person retired and he was very isolated. And he said that his only companions were his co-workers. And when he retired, he became completely isolated and he wanted assistance in dying. So that's a kind of slippery slope that we spoke about. So it's very difficult to say that one type of suffering is unbearable and the other type of suffering is not unbearable, when there are different types of unbearable suffering, and these are not only medical sufferings, but other types of suffering.
Can I just tie that point back to your earlier point about wealth? Because in Canada, so I've read, I haven't corroborated it, but in Canada there are cases where someone who, a military veteran who, because of his involvement in military action, was suffering from post-traumatic stress disorder, was offered voluntary euthanasia without asking for it, was offered it, and that other people who were suffering from unable to get housing or were in credit card debt have also been offered voluntary euthanasia because they were suffering unbearably. And now I find that extraordinary. I've not been able to corroborate it. I've read it once in an article. But if it's true, it shows in a sense how the concept of unbearable suffering, how flexible, how amorphous, how indefinite it is. And tying into the issue of wealth, you were saying that one shouldn't grant a right to assisted suicide, voluntary euthanasia, except if you're a wealthy society. I'd qualify that and say, well, no, it's got to be wealthy and equal. Because in the case of Canada is a wealthy society, but clearly some people in Canada find themselves in social circumstances so distressing they prefer to kill themselves. But then I wonder, is there a wealthy society in the world where that isn't the case? And then I think, is there a healthcare system in the world that doesn't feel itself starved of resources? I mean, in the UK now, well, 40 years ago we spent 10% on defence and 2% on health. Now we spend just over 2% on defence and 12% on health, and the demand for healthcare resources just goes up. There are never enough. So I guess I wonder whether there will ever be a society on Earth that is wealthy enough, equal enough, and has a well-resourced enough healthcare system to warrant the granting of assisted suicide and voluntary euthanasia without the risk of some citizens, as it were, being pressed by social circumstances into choosing death.
Yes, I think the pressure is the greatest difficulty, because many people who argue in favor of allowing euthanasia, they say that it will not be obligatory, it will be free. So if I give a freedom to people, they can live with that freedom or they can leave it there, so nobody is forced to live with that freedom. But I'm not sure that this is true, because if we give an opportunity, people feel a kind of pressure to make use of that opportunity. So for instance, if I have relatives who have to treat me because I'm very ill, and they are very tired because they have to do a lot of effort, I can feel that perhaps I overburden them, and if there is the possibility of active euthanasia or physician-assisted suicide, I feel an implicit pressure to choose it, in spite of the fact that perhaps they don't do that, but still I can feel. So even if a society is possible, there will be a tremendous pressure, although only implicit pressure in the best case and not explicit pressure, but there will be an implicit pressure that don't overburden your family, don't overburden the healthcare system. There is an easy way out, and it's so that's a danger, and I think it questions the autonomy of the choice.
That was the point I was going to make. So yes, we've all agreed there are huge difficulties with the suffering argument in terms of how you assess suffering, its subjectivity, its definition, and so on. But there are similar problems with the autonomy argument, because exactly as you say, autonomy sounds a wonderful principle from the philosopher's chair, you know, that everyone is self-determining and I live my own life and so on. But in the real world, how do we ever know that someone is making a genuinely free, autonomous decision? In the real world, does anyone ever make a genuinely free, autonomous decision? Aren't we influenced in all sorts of ways by other people? And in particular, in a world where there are too many elderly people, where there's not enough resources and there are not enough young people, it doesn't take a genius to see what the implicit pressures will be on older people to take their own lives. And this could be seen actually as a very altruistic, instead of being a terrible burden to my relatives and burning up all the resources of the family, what a noble thing to do, to accept a free autonomous decision to sacrifice my life so that my children can have more money, so that they're relieved of my care and so on. So in the real world, autonomy is an extremely slippery concept, and the possibility of all kinds of emotional coercion, implicit, unintentional, intentional, and so on, it doesn't take a genius to see what the risks are.
Just a slight variant on that, relating to a remark you made earlier, John. It strikes me that if it comes to be seen, generally speaking, as rational for you to choose assisted suicide under certain conditions, I'm a physician, you're in those conditions, you decide to choose assisted suicide, and I assist you, and that's rational. Then I come across a Joseph in exactly the same conditions, who refuses to choose assisted suicide, and he's in a bed, he's in a hospital bed I need as a doctor. Even if I obey the law and do not kill you, Joseph, I may well communicate to you that really it's your social duty to do as John did, because that was rational, and what you're doing is irrational. So it's very subtle, but I think the big point is we shouldn't imagine if we change the law and change the practice that our social views and norms will remain the same. They won't, they will change.
To tell the truth, if I can say something, I think it's by and large an empirical question, and because it's something very similar whether carrying of arms must be free or not, because there is an argument, that if you have a right to carry arms, then it's better than not to carry arms, because if you don't have a right to carry arms, then it means criminals will have arms, you will not have, so you can't protect yourself. But if you have a right to carry arms, you can protect yourself against the criminals. This is the argument which is very convincing at the first sight. But we know the empirical evidence that mass shooting is every day in the United States, where there is a right of such a thing. And in Europe, it's much less, because we don't recognize that right. So it's not only a theoretical question, I think. It must be an empirical one. And again, as far as I know, there is no abuse in the Netherlands or in Belgium. But it doesn't follow that in other countries there wouldn't be an abuse. So that's the reason that I think that it is culture specific. Some cultures perhaps can afford it, but other cultures cannot, because they have different wealth, different follow ruling tendencies, and different culture.
Yeah, I don't agree with you that there's no evidence of abuse in the Netherlands. I know a number of people working in the Netherlands who have stated publicly that they're very concerned about what's going on in the Netherlands. So, but I agree with you that empirical evidence is really important, and that, as you say, we have these various laboratories around the world, and having detailed information about what is actually happening and what is the change in the social culture is important. For instance, one of the empirical evidence is that in the Netherlands there's really quite evidence of specific distress caused to doctors by being involved in euthanasia. I mean, surprise, surprise, the experience for a doctor of injecting a patient and watching them die at the end of the needle is not something that is of no emotional consequence. One medical, in the Netherlands, most euthanasia is performed by family practitioners in the patient's home. One recommendation was that doctors should not drive themselves to these appointments, because experience was that there was an increased instance of road accidents. I read a description of a doctor who said, "I hate doing this. It happens every so often. I always try and avoid it. I try to persuade the patient not to. But if in the end the patient says, 'You're not going to abandon me, doctor,' I say, 'I always agree to do this, but I agree to do it on a Friday afternoon. I go to the patient's house, I perform the deed, I fill out the forms, I inform the coroner, and then I go for long walks in the forest. I listen to a lot of Bach, I read Goethe, and then I try to get my head ready to go back to work on Monday morning. And this was a doctor who was fundamentally in favor of the law, but it just, in other words, unintended consequences. And I know people who said, I can't practice medicine in the Netherlands because that demand on me is unacceptable.
But it is voluntary from the part of the physician. The physician can say no. It is not a right to get euthanasia. It is a kind of negotiation between the physician and the patient. And that is usually the argument that educated patients are able to persuade the physician more than uneducated patients. And that's the reason that there is a separate institution which gives euthanasia to those who can't persuade their physician to do euthanasia. And on the other hand, the physician have a right to not to do it, in the same way as a physician has a right not to do abortion if it is against his conscience. But according to opinion polls, 80% of physicians, or perhaps 90%, is in favor of euthanasia. There is only 7% of physicians who is against it. But you are absolutely right. It can be a terrible experience for a physician. On the other hand, it's also a terrible experience to see the patient suffering unbearably, because there is unbearable suffering. So I think it's a kind of ultimate solution, which is not an argument in favor of that, but I think it works both ways. It's terrible to see a patient suffering, and it's terrible to end the patient's life. That's true, absolutely.
Now, all of you at least once mentioned the famous slippery slope, at least with regard to the Netherlands or I think Canada. But there are more countries that legalized active euthanasia or assisted suicide. So isn't there at least one good example of a country that didn't go down this slippery slope? And if there's no example of a good country that didn't go down the slippery slope, then which is the worst example of going down this slope?
I think, as far as I'm read, in the Netherlands, the Belgium, they didn't go down the slippery slope. There are, of course, arguments against it, but basically they are satisfied, and the numbers are increasing. In Canada, I think the situation is more recent because it has begun much later, and perhaps it's different in a sense. But as far as I know, in the Netherlands there is no, but it was a 50 years development because it began in the 1970s. But I emphasize that this doesn't prove that in other countries it would go smoothly, because it can be the case that it would be terrible in the Netherlands. But of course, a person from the Netherlands would be more authentic than me. I can trust only my readings, but usually very few counterexamples can be read. Some can be read, but mostly physicians and patients are satisfied with that.
I accept what you say. I'm not quite sure I agree. My perception, and I need to go and confirm my perception, is that even in the Netherlands, the initial conditions for eligibility have been relaxed progressively. And now, not everyone thinks that's a slippery slope that's bad, but my clear view is that often the advocates of assisted suicide, voluntary euthanasia, begin with strict conditions, and these are then accepted, and then progressively, partly because it doesn't make sense to grant the possibility to terminal patients, not to chronic, to people suffering from physical ailments and not to mental ailments. So progressively the logic leads to a progressive relaxation of the conditions. And I think that's taking place in the Netherlands, but I have to confirm it. Certainly in a short time, 8 years in Canada, the relaxation has been, I think, quite dramatic. Yeah.
Yes, that's absolutely true. For instance, in the Netherlands, for a long time, euthanasia of children was allowed only until the age of 1 and from the age of 12. But children between 1 and 12 years old couldn't be euthanized. And that caused a lot of problems. And in 2020, this has been eliminated. So no, today children can be euthanized, of course, with very strict conditions. But I can't resist to tell the arguments of the Dutch, because usually on conferences, when people are flabbergasted and ask the Dutch whether they have read the Bible, they have read the injunction not to kill, they usually say that, look, this is everywhere in other countries as well, but it's kicked under the rug. What we do is transparent, it can be checked, while other countries cannot be checked. And I just read, you know perhaps better than me, that in England, King George V, who died in 1936, and he died a natural death. And in 1986, his physician's memoirs were published, and it turned out that he killed the king with morphine and cocaine because he saw that this life is terrible. And this is an example that it happened, although it's not legal, but if a physician was concerned with the plight of the patient, he did it illegally and under the rug. And after he died and his memoirs were published, we know that this happened. So this is the argument of the Dutch, that this happens everywhere. And if this happens, because physicians are human people and they can't see the suffering, the unbearable suffering of people, then it's better to do it publicly and with control than to do it in the dark.
I suspect John and I will say the same thing. I guess I'd want to know more detail about exactly what happened, because as you describe it, it could have been the king's doctor decided that the king's physical suffering was such as to require this dosage of analgesic, which might well kill him, and it did. But I want to know exactly why did the doctor give the king this dosage of analgesic, whatever it was, if it was calibrated to what the doctor estimated to be necessary to overcome the pain. That's not immoral, it's not illegal. If the doctor decided that the king's life wasn't worthwhile, and it's time that he went now rather than later, and decided to kill him, morally speaking and legally speaking, that's a different thing. But from your description, it's not clear.
Yes, I would just point out that medicine in the 1930s and 40s compared with medicine in 2020 is a completely different game. I've heard this argument many times, that in reality British doctors are quietly killing patients here, left, right and centre.
Not only British, everywhere.
Yeah,
but not against the British, everywhere it is the argument.
But the reality is, if you practice medicine in Britain in 2020, you discover such an astonishingly bureaucratic and regulated system that the idea that doctors can slip in some drugs and nobody notices is just ludicrous. It simply doesn't happen. It might have happened 60 years ago. Medicine was a very different ballpark. But in such a highly controlled, scrutinized, assessed, regulated health service, every doctor knows. I know that if I happen to slip one of my babies a lethal dose in order to kill their life, I'm basically risking destroying my career. I'm mandatory life sentence, stripped of my professional status, because it is simply not possible to do these things in a dark hole anymore. And therefore, it isn't happening. To say that there's not the occasional case, of course there's the occasional case. We had a tragic case of a highly regarded family practitioner who turned out to be a mass murderer and who had probably killed more than 100 people before he was spotted. But it's precisely because of cases like that that a whole raft of new regulations are introduced to scrutinize the cause of death and scrutinize how drugs are being used. So I think it is genuinely true that in present, in the UK, doctors are not intentionally killing their patients, and yet we have still not got legalized euthanasia. We feel in general, the majority of doctors still in the UK believe that palliative care is a better solution to pain and distress and suffering at the end of life than is changing the law.
Yes, I must clarify, of course, I don't mean that English doctors, of course, everywhere this is a problem. And it's not intentional killing. You know, there was an examination in the Belgium examination, and intensive care specialists were asked about their practice, and they were full of guilty conscience because they didn't know what they do is tolerable or not, although in the Belgium active euthanasia is permitted. But this is not such clear-cut cases. If I increase the dose of morphine, I know that it causes some respiratory depression. Of course, this is not my aim. It's a foreseen but unintended consequence of my act. But we never know what is that dose which is already too much because it's naturally the resistance is increasing. And that's the reason that many physicians have guilty conscience. They don't want to do anything bad to the patient, but still it's not clear-cut. And that is what usually the Dutch are speaking, that under the rug things happen which is unavoidable because this is the nature of the profession. And if it happens, then it must be done in a transparent way. Although I agree that in most countries this happens very rarely, and in Britain as well, and everywhere else as well, so it's not a typical situation. But it happens. Various votes, anonymous surveys showed that some doctors said that they did this, but of course it's anonymous. And that's the argument of the Dutch.
Unfortunately, we will soon have to wrap up because our time is long over. But I just want to ask one more question because it interests me that, however slippery is this slope, it still seems like that people around the West at large support the introduction of some forms of active euthanasia. Why is it?
If you're referring to polls, it's because of the nature of the question asked. So in the UK, I'm told, I've read, 80% of the population support assisted dying. But note the phrase, assisted dying. This obscures the difference between assisting someone to die through palliative care and assisting someone to kill themselves. So the very choice of the phrase in the question shapes the response, because who can possibly object to helping someone who's in the process of dying? If the language was changed to assisted suicide, support would drop. If it was then pointed out some of the risks involved in granting this right, it would drop further. Apparent support for legalization of assisted suicide or voluntary euthanasia depends very heavily on the question put. And that's why in the UK, in 2015, 8 years ago, when this was last discussed in Parliament, yes, 80% of the population apparently supported it, but members of Parliament, both in the lower house and the upper house, rejected it, partly because, unlike the general population, through debate, they were exposed to all the complications and all the risks and ramifications, and exposed to the gap between what the law strictly says and what would actually happen in a healthcare service under pressure. And they decided it was too risky. But the general population is not exposed to those arguments.
I totally agree with that, but there is an additional factor which every experienced doctor recognises, and that is this curious fact that if you were to ask someone sitting at ease in a bar with a pint of beer in their hand, and you say, you know, feeling well, and you say, if you were diagnosed with a terminal illness that could cause a lot of suffering, what do you think you would want? And the majority of people say, well, of course, if that happened to me, I'd say, well, doc, I've had a good life, and I wouldn't want any kind of invasive treatment. And yet, in my clinical experience, when it's actually happened to me, I've been the doctor telling someone in the middle of the night that they have a terminal condition such as cancer and so on. In my experience, virtually every person says, I will have whatever treatment it takes, doc. I don't care how much it hurts. I just want to try and survive. In other words, our ability to predict how we would respond and what is important to us facing life-threatening terminal illness is almost impossible until you've actually been there. And this, of course, is a huge problem, therefore, in terms of doing general referenda, democracy generally, because how can you know what it's like? And it's very interesting that basically the closer you are to the actual dying process, the more that people are opposed to the legalization of euthanasia.
You know, I can't tell exactly the cause, but I think basically it's connected with many factors. First is that the paternalistic physician-patient relationship gives way to a more equal physician-patient relationship where the autonomy of the patient is paramount, which means that patients want to control what should be done with them and not, and that's the first. So autonomy, which is to the extreme, if I ask this, I will get this. It's not new. In Roman times, it was quite normal if somebody committed a public suicide among his friends, and the physician was a kind of servant who helped him to commit suicide, and of course it was prohibited. So we go back to that. So the first is the autonomy. The second is, I think, the hedonistic worldview of people, that life is valuable only for when there is pleasure, and there is no hope for pleasure, but only suffering, it's invaluable. And the third, I think, is secularization, because I think the basic arguments against euthanasia are religious arguments, and the secularization of the societies mean that this is valid for only those who are religious, and on a secular basis, it's very difficult to say decisive arguments against euthanasia. A lot of practical arguments can be said, and I agree that practically it would be disastrous for many societies, but very few theoretical arguments can be said, and that's the reason that the secularization leads to that. But I think the situation is not solved, because there are already 9 countries where active euthanasia is practiced, and a lot of countries where physician-assisted suicide. I think decades are needed to draw the conclusion and to examine whether the slippery slope argument is valid or not. So I think we are not at that point still. But I'm sure that in many societies it's unacceptable. And for instance, in Hungary, I think it would be unacceptable. Perhaps in the United Kingdom, if I understand you well, it would be unacceptable. So these laboratories are only a few in the world.
Thank you. Thank you. For me, it was a great help hearing these different perspectives from philosophy, ethics, and especially medicine. And I hope the audience also came much closer to understanding the depth of these moral and practical dilemmas. So thank you all for coming, and especially thank you, professors, for this fascinating discussion.